Hello, I'm Eric Strong from Strong Medicine, and in today's video on the cardiovascular system, I'll be discussing cardiac mechanics, referring to the physical process of the myocardium contracting and relaxing with each heartbeat. The learning objectives today: to define preload, afterload, and contractility, and to describe the factors that influence each. To calculate stroke volume, ejection fraction, cardiac output, and cardiac index, and to draw the Frank-Starling curve. The terms preload, afterload, and contractility, they all suffer from the same problems. First, none have a universally agreed upon definition, and second, because they are difficult to explain and to understand, the common bedside understanding of them by healthcare professionals is usually a significant oversimplification of the relevant physiologic principles. For this discussion, I'm going to take a middle-of-the-road approach that goes into more depth than the bedside understanding, but which still steers relatively clear of nuance that is not clinically relevant. While the concepts of preload, afterload, and contractility can be applied to the mechanics of either ventricle, in common usage and how I'll use the terms in this video and in the rest of the series, they will refer specifically to the left ventricle unless otherwise stated. I'll go through them one at a time. Preload can be defined either as the wall tension experienced by the left ventricle just before the onset of systole, a moment known as end diastole, for which the best, though imperfect, surrogate is left ventricular end diastolic pressure, or as the sarcomere length in the left ventricle at end diastole, for which the best surrogate is left ventricular end diastolic volume. Of course, LV pressure and LV volume are related to one another based on the compliance of the left ventricle. And here's a graph of that relationship, the pressure-volume curve. If the scale of this graph seems a little off, it will make more sense when we return to the graph when discussing pressure-volume loops in a future video in this series. We see that during diastole, the relationship starts as linear, but starts to curve upwards at high volumes. In other words, compliance of the LV starts to rapidly decline when it's extremely stretched, as there is only so much blood the LV can hold before the walls cannot stretch any further. This is an important phenomenon, particularly for patients in heart failure, whose kidneys initially tried to expand their blood volume to increase both LV pressure and LV volume, ultimately in an attempt to increase how much blood the heart is pumping. But when the total blood volume reaches a critical value, the addition of more intravascular fluid by the kidneys results in an increase in LV pressure without a significant increase in LV volume, leading to symptoms of vascular congestion in the lungs. Also, if the general compliance of the LV worsens due to something like infiltrative diseases of the myocardium such as amyloidosis or sarcoidosis, the overall curve steepens. So for a given LV volume, the LV pressure is higher, also predisposing the patient to symptoms. Compliance of the LV is not only dependent on the compliance of the myocardium, but is also dependent on compliance of the pericardium, which can be adversely impacted by large pericardial effusions or by pericardial fibrosis. So at this point, we know two major things which impact preload: total blood volume and ventricular compliance, including pericardial compliance. Preload is also affected by the heart rate and heart rhythm. For one thing, there is an inverse relationship between heart rate and preload, because as heart rate increases, the duration of diastole shortens more than duration of systole. Thus, at faster rates, an overall less proportion of time is spent in diastole. Less diastolic filling time means less blood moves from the left atrium to the left ventricle. In addition, arrhythmias in which there is no atrial kick, such as atrial fibrillation, will necessarily also result in less left ventricular filling during diastole. So in summary, preload is affected by the total blood volume, the heart rate and rhythm, ventricular compliance, which includes how thick the wall is. It also includes the more nebulous category of relaxation properties of the myocardium, rarely called lusitropy. which can be impacted by things like ischemia. Preload is affected by pericardial compliance. And last, although I haven't mentioned it yet, it can also be affected by intrathoracic pressure. For example, in the presence of positive pressure ventilation, in which you can think of the air being pushed into the lungs by a ventilator, rather than the lungs sucking in air from the room, that additional pressure decreases the pressure gradient, driving blood back from the systemic circulation, reducing preload. The most general definition of afterload is the force opposing ventricular contraction during systole. That is, the mechanical load that the left ventricle must eject blood against, sometimes defined as the wall stress or wall tension during systole, framing which allows for a nice parallel with preload as being the wall stress or wall tension at end diastole. Afterload is often used interchangeably with blood pressure or vascular resistance, but this is a significant oversimplification. To see one way in which this is an oversimplification, we need to review the law of Laplace. The law of Laplace, formulated long before we knew anything about cardiovascular physiology, concerns fluid or air-containing spheres, which in this case will be an extremely rough approximation of the shape of the left ventricle. If we cut the sphere in half, we can see the wall and the interior cavity. The tensile stress experienced by the wall is very dependent on the pressure. It's usually assumed or simplified that the only relevant pressure is the intraventricular pressure, that is the pressure within the ventricular cavity, which is determined mostly by systemic vascular resistance, itself determined largely but not completely by arterial constriction versus dilation, which I'll talk about more in a future video. The intraventricular pressure is also determined by arterial compliance, that is, how much the aorta and large arteries momentarily distend during systole to accommodate the sudden ejection of blood before recoiling back during diastole. The less compliant the arteries, for example due to calcifications and atherosclerosis, the higher the afterload will be. However, instead of the intraventricular pressure, actually the most relevant pressure when discussing afterload is more precisely the transmural pressure, which is the difference between the intraventricular pressure pushing outward from the inside and the intrathoracic pressure on the outside. Under normal circumstances, the intrathoracic pressure is both small enough to be ignored and is usually negative due to the mechanics of respiration. But as we did when we were discussing preload, you can also imagine a patient on positive pressure ventilation in which that positive intrathoracic pressure is transmitted to the heart, squeezing it a little from the outside, reducing the overall stress felt by the wall. The law of Laplace states that the wall stress equals the transmural pressure times the radius of the entire sphere, divided by 2 times the width of the wall. In other words, in circumstances where intrathoracic pressure can be ignored, afterload is proportional to the left ventricular pressure and to the left ventricular radius, again using the approximation of the LV being spherical. Although we are talking about this in the context of afterload, the law of Laplace can be applied to preload as well, particularly if we define preload based on wall tension rather than sarcomere length. Conflating afterload with vascular resistance is also an oversimplification because left ventricular pressure also depends on LV outflow tract resistance. This is usually low enough to be ignored, but in a patient with pathologic severe narrowing of the aortic valve, a condition known as aortic stenosis, or in a patient with a genetic condition called hypertrophic obstructive cardiomyopathy, this additional resistance can be significant. In summary, the most clinically relevant influences on afterload is increased by increased vascular resistance, such as hypertension, and a class of medications called vasopressors, by outflow tract obstruction, such as aortic stenosis and hypertrophic obstructive cardiomyopathy, by increased LV chamber size and volume, and by decreased arterial compliance. Afterload is decreased by decreased vascular resistance, decreased LV chamber size, such as in a patient who has received diuretics, a class of medications which increase the production of urine, and positive pressure ventilation. As with preload and afterload, defining contractility is tricky because how a physiologist defines it and how clinicians typically use the word are different. I think it's most clinically helpful to consider contractility to be the intrinsic strength of myocardial contraction that is independent of both preload and afterload. Under normal conditions, it is primarily influenced by the autonomic nervous system's regulation of cytosolic calcium. Contractility is increased by sympathetic activation, by inotropes, which is a general category of medications circularly defined as those which increase contractility, and increased heart rate via something called the Bowditch effect. This is the phenomenon in which cardiomyocytes have less time to move calcium out of the cytosol during diastole when diastole is shorter. Thus, cytosolic calcium concentration ends up being higher than normal. Contractility is decreased by parasympathetic activation, beta blockers and calcium channel blockers, and pathologic states which interfere with either calcium handling by the cell and or ATP generation, which includes ischemia and infarction, inflammation of the myocardium, severe acid-base derangements, and hypothermia, among many other things. So why do we care about preload, afterload, and contractility? We care because they are the determinants of stroke volume, which is the volume of blood ejected from the left ventricle during systole. Stroke volume is related to the ejection fraction, which is the percentage of blood in the left ventricle that's ejected during systole. Ejection fraction is clinically used as a semi-quantitative surrogate for contractility and overall systolic function, although we're going to get back to that issue a little bit later in this video. These two values are calculated as such. Stroke volume equals end diastolic volume minus end systolic volume. Ejection fraction as a percentage equals stroke volume divided by end diastolic volume times 100. The normal range for ejection fraction, or EF, is most commonly stated as 55 to 70%, though some references include 50 to 55% as normal, while others classify 50 to 55% as borderline. How is ejection fraction used in medicine specifically? Most prominently, it distinguishes different types of heart failure, specifically heart failure with preserved ejection fraction, colloquially known as diastolic heart failure, and heart failure with reduced ejection fraction, colloquially known as systolic heart failure. EF guides management in heart failure, specifically being one of the criteria for initiating certain medications such as beta blockers and aldosterone antagonists, and for placement of an implantable cardiodefibrillator. EF also guides the timing of valve replacement in valvular heart disease. Related to management questions, it aids in prognostication in a variety of diseases, including heart failure and post-myocardial infarction. Another, perhaps less common but nevertheless important role of EF is monitoring for chemotherapy-related cardiotoxicity. However, there's a big asterisk when it comes to using the EF in these situations that we're going to come back to when discussing Frank-Starling in a few minutes. There are many different ways to measure a person's ejection fraction. The most common is echocardiography, which is another name for an ultrasound of the heart and which is often referred to as an echo. With echo alone, there are multiple approaches to measuring EF, but the most conventional is the biplane method of discs. In this method, two different echo views are obtained. The apical four-chamber view, in which the ultrasound probe is placed at the apex of the heart, usually near the intersection of the midclavicular line and the fifth intercostal space. This provides one two-dimensional view of the left ventricle in systole and diastole. The ultrasound probe is then rotated 90 degrees to acquire another view of the LV in systole and diastole. Tracings of the LV cavity are divided into a predetermined number of sections, usually 20, and then using the two different views, the LV cavity is then subdivided into a stack of ellipsoid discs at end systole and end diastole, whose individual volumes can be added to provide end systolic and end diastolic volumes, from which ejection fraction is calculated. There are many different variations on this method, all of which need to strike a balance between making as few assumptions about LV geometry as possible, while also making the image acquisition as practical as possible. In addition to challenges with accurately measuring EF, there's also a problem with using it as a surrogate for overall systolic function in patients with valvular disease. For example, consider a patient whose end diastolic volume is 110 milliliters and end systolic volume is 50 milliliters. This makes their stroke volume 60 milliliters and their ejection fraction 60 divided by 110 or 55%, which is normal. But what if the patient has severe mitral regurgitation, a condition in which their mitral valve is incompetent and allows the backwards movement of blood from the left ventricle to the left atrium during systole? If a third of their ejected volume moves backwards, the effective stroke volume is only 40 milliliters. This would suggest that the conventionally calculated ejection fraction of 55%, if used as a surrogate for overall cardiac function, is an overestimate. Framed a little differently, in a patient with severe mitral regurgitation and otherwise normal cardiac function, we would expect a higher than normal ejection fraction as the low pressure of the left atrium significantly reduces afterload. The same general problem is present for patients with aortic regurgitation, in which significant volume of blood falls backwards from the aorta into the left ventricle during diastole. That regurgitating blood counts, so to speak, as part of the stroke volume when measured by echo, even though it doesn't immediately enter the systemic circulation. A quantifiable physiologic parameter of overall cardiac function, whose measurement does not suffer from some of these same limitations, is cardiac output. The cardiac output is the volume of blood ejected forward from the heart per unit time. It is usually reported in liters per minute and is sometimes abbreviated Q, which is a common abbreviation in physics for fluid flow. In order to correct for differences in body size so that cardiac outputs can be compared to a reference standard, we use the cardiac index, which is the cardiac output adjusted for estimated body surface area. Cardiac index is reported in liters per minute per meter squared. Mathematically, the cardiac output is the stroke volume times the heart rate. In other words, the blood ejected from the ventricle with each contraction times the number of contractions per minute. And of course, it's assuming that all the blood's moving forward. And cardiac index is just cardiac output divided by body surface area. A normal cardiac index is about 2.5 to 4.0. However, physicians do not typically calculate the cardiac output and index this way in real-life clinical situations because of the problems we saw with measuring stroke volume and ejection fraction. It involves a lot of assumptions, and it's practically impossible to do accurately for patients with irregular rhythms. So instead, there are a number of interesting techniques to measure cardiac output. They fall into invasive or traditional versus non-invasive categories. All of them have advantages and disadvantages. As a general rule, the invasive techniques are considered more accurate, while some of the non-invasive techniques can provide real-time, continuous cardiac output monitoring. Which technique is used for a particular patient depends somewhat on the patient and the clinician and the clinical situation, but is probably most dependent on ward and institution level preferences. For example, a particular cardiac care unit might only measure cardiac output using the Fick method, while an ICU in the very same hospital may have fully transitioned to non-invasive techniques only. I'll briefly discuss the invasive techniques since these are still relatively common in the US. Historically, the first described technique was actually still pretty much the standard when I was a student. That's the Fick method. Conceptually, the Fick method is based on the principle of conservation of mass. Specifically, the amount of oxygen leaving the lungs via the pulmonary veins and ultimately the amount in the systemic arteries is equal to the amount of oxygen returning from the body via the pulmonary arteries plus oxygen added from ventilation. This oxygen added via ventilation is the oxygen that's consumed by the body's tissues. The calculation for this is cardiac output times the O2 content of mixed venous blood that is blood from the right ventricle or preferably pulmonary artery that's been fully mixed, since the O2 content in blood returning via the IVC and SVC are not necessarily the same, plus O2 consumption equals the cardiac output times the O2 content of arterial blood. With some quick algebraic rearrangement, we get this. And O2 content of blood is approximately equal to the hemoglobin times the O2 saturation times the correction factor, which gives us the final practical form of the calculation. So to calculate cardiac output, we need to know the patient's hemoglobin and their venous and arterial O2 sats, all of which can be measured at the bedside. But wait, you're probably also wondering about that O2 consumption variable. Well, that's the main problem with the Fick method. Directly measuring O2 consumption, this can be done using equipment colloquially referred to as a metabolic cart, but in practice this is not common, and clinicians often make educated guesses about O2 consumption from published nomograms based on their patient's age, sex, and weight, and these may or may not apply well in that specific situation. Another disadvantage is the need for an invasive measurement of venous O2 sat using a central venous catheter, preferably a pulmonary artery catheter, which can measure true mixed venous O2. The second invasive technique is thermodilution. Thermodilution requires also a pulmonary artery catheter, this one with a thermistor at the distal end. A thermistor is a resistance thermometer or resistor whose resistance is dependent on temperature. So in other words, it can very rapidly measure changes in temperature in real time. A small amount of relatively cold saline solution of precisely known temperature and volume is injected from the proximal port of the catheter located in the right atrium. And the thermistor records the change in temperature that it experiences as the cold fluid passes by it while diffusing and mixing with the surrounding warm blood. This generates a curve of change in temperature as a function of time, in which the cardiac output is inversely proportional to the area under that curve. This is done automatically by a computer. There's no need for healthcare professionals to do calculus at the bedside. For a patient with low cardiac output, it takes longer for that cooled blood to make its way completely past the thermistor, resulting in a wider curve and larger area. Disadvantages of thermodilution include that, as mentioned, it also requires an invasive pulmonary artery catheter, and it's also not accurate in the setting of intracardiac shunts and tricuspid regurgitation. The Frank-Starling mechanism, also known as the Frank-Starling relationship, Frank-Starling law, and when illustrated as a graph, as the Frank-Starling curve, is the observation that the stroke volume is dependent on left ventricular end diastolic volume. At low and normal volumes, stroke volume increases with increasing LV-EDV. This is a critically important autoregulatory mechanism that accounts for things like the moment-to-moment changes in preload secondary to the respiratory cycle, or to abrupt changes in position. It allows the stroke volume from the right and left ventricles to match each other in real time, even if pathology is present that asymmetrically affects one ventricle more than the other. In patients who experience a brief interruption in their cardiac rhythm, for example from a premature depolarization that fails to produce contraction, the subsequent unusually long ventricular diastole will result in an unusually high amount of diastolic filling, which would be a problem if the stroke volume could not immediately increase with the next ventricular contraction. When people experience palpitations related to premature beats, it's usually not the actual premature depolarization that they sense, but rather the post-pause accentuation of stroke volume that leads to a single, unusually strong pulse beat. However, there is a limit to this mechanism. As you can see from the graph, as the LV-EDV increases into the higher than normal range, the increase in stroke volume becomes less and less until the curve eventually flattens. Contractility plays an important role in the Frank-Starling mechanism too. In patients whose contractility is increased, for example, by activation of the sympathetic nervous system or by administration of positive inotropic medications, this curve shifts upwards so that stroke volume is increased at any given volume, and it takes higher volumes to reach the flat part of the curve. And for patients whose contractility is decreased, for example due to ischemia, heart failure, or metabolic derangements, the curve is shifted downwards. The plateau is seen at lower volumes, and in some cases, stroke volume may even decrease at extreme end diastolic volumes. There have been multiple hypotheses as to the molecular basis for the Frank-Starling mechanism, but they are as of yet unproven. The current leading hypothesis is that physical stretching of the myofibrils somehow increases their sensitivity to calcium. Some of you may already be correctly speculating that the stroke volume end diastolic volume relationship is dependent not only on contractility, but it's also dependent on afterload as well. Afterload is literally defined as the total mechanical force that is opposing ventricular contraction. So naturally, higher afterload will shift this curve downward, and lower afterload will shift it upward. The last point to make here is going back to ejection fraction, and how ejection fraction is also dependent on LV/EDV. Remember that we calculated it as the stroke volume divided by the end diastolic volume. When the curve starts to flatten, it means the stroke volume is no longer increasing with increasing end diastolic volume, so EF will not necessarily decrease, even if contractility and afterload remain unchanged. This fact is very frequently but inappropriately ignored when monitoring a patient's response to heart failure management. If between 2 points in time, the EF in a patient with heart failure increased 5%, does that mean that their chronic heart failure treatment is working? Or is it just that the patient skipped their usual salt-laden breakfast the day of the second measurement? And for that matter, just like the effect of afterload on stroke volume, afterload affects EF too. So a patient who forgets to take their medications the morning of their echo could have their EF measured as lower than it normally would be. These are some more reasons that EF should really not be used as the primary metric for monitoring heart failure, despite the fact that this is done very commonly in routine practice. Let me summarize. Preload can be defined as either the LV wall tension or LV sarcomere length at end diastole. Afterload is the force opposing ventricular contraction during systole. And contractility is the intrinsic strength of myocardial contraction that is independent of both preload and afterload. As mentioned earlier, these are not necessarily consensus definitions, and not every physiologist and clinician uses the words in precisely the same way. With preload, afterload, and contractility, none of these three are directly measured in routine clinical practice. However, there are common, convenient, and imprecise bedside surrogates used. For preload, clinicians often use central venous pressure as measured via a central venous catheter in the right atrium, or is estimated on exam using the jugular vein. For afterload, they use systemic vascular resistance, and for contractility, they use the ejection fraction. All of these surrogates, but in my opinion particularly the EF, should be applied with caution. Despite just talking about the problem with oversimplifying these complex physiologic principles, I'm going to give you an oversimplified analogy for them. Imagine a slingshot. How far the band is stretched just before letting go is analogous to preload. The mass of the rock is analogous to afterload. And the intrinsic recoil of the band, that characteristic that is independent of the degree of stretch, is analogous to contractility. How far the rock ultimately travels is sort of like the stroke volume. So the further the band is stretched and the more recoil it has, and the less massive the rock is, the farther the rock will travel when released. The four equations that you need to remember: the calculation of stroke volume, ejection fraction, cardiac output, and cardiac index. And last, the Frank-Starling curve illustrates the nonlinear relationship between LV/EDV and stroke volume. That concludes this video on cardiac mechanics. As always, if you found the video helpful, please consider sharing it with classmates and colleagues, and consider subscribing to Strong Medicine for the rest of this ongoing series on the cardiovascular system, as well as a large collection of videos on other medical topics.